This is Lecture 07, Pulmonary Embolism and Deep Vein Thrombosis. The ED job is to recognize the dangerous phenotype, choose the right diagnostic test for the right risk group, and treat physiology before certainty when the patient is unstable. Most pulmonary emboli are managed with anticoagulation, but the unstable patient needs thrombolysis or catheter-directed therapy without delay. The objectives are these. First, recognize the dangerous PE phenotypes, massive, submassive, and low risk. Second, apply pretest probability tools, PERC, Wells, and PESI. Third, use D-dimer correctly with age adjusted cutoffs. Fourth, interpret bedside echo and ECG findings of right ventricular strain. Fifth, know the thrombolytic and anticoagulation anchors. Sixth, manage DVT, including phlegmasia. And seventh, navigate special situations, pregnancy and outpatient PE treatment. The ED mindset for PE is to treat physiology before certainty. The unstable patient with high suspicion may need empiric anticoagulation or thrombolysis before confirmatory imaging. Sequence matters. Risk stratification is the diagnostic strategy, not a single test, and the right diagnostic test for the wrong risk group is a board trap. Pulmonary embolism risk factors include recent surgery, immobility, cancer, prior venous thromboembolism, estrogen exposure, pregnancy and postpartum, obesity, smoking, thrombophilia, and central venous catheters. The dangerous PE phenotypes are syncope, hypotension, shock, hypoxia, new atrial fibrillation with hemodynamic compromise, and cardiac arrest. Post-operative new atrial fibrillation with shock should make you think pulmonary embolism until proven otherwise. The ITE buzzword frame is Virchow's triad: stasis, hypercoagulability, and endothelial injury. Every classic vignette risk factor maps to one of those three legs. The classic PE presentation is dyspnea, pleuritic chest pain, and tachycardia. But the classic presentation is the minority. Many patients present atypically, syncope without dyspnea, altered mental status, isolated hypoxia, new atrial fibrillation, or hemodynamic collapse. The board concept is that PE has no pathomnemonic presentation. Risk factors plus clinical suspicion drive the workup. Classic mimics on the test: acute coronary syndrome, pneumothorax, pneumonia, costochondritis, anxiety, and aortic dissection. If the vignette gives you pleuritic chest pain plus a unilateral swollen leg, the distractor is MSK. The answer is PE. ECG and bedside echo support the diagnosis when the patient is too unstable for CT. The most common ECG finding in PE is sinus tachycardia. The S1Q3T3 pattern is the classic ITE buzzword, but is actually uncommon, present in less than 20% of cases. Other right heart strain signs include new right bundle branch block, right axis deviation, and T-wave inversions in V1 through V3. McConnell's sign is the high-yield echo finding, right ventricular free wall hypokinesis with preserved apical contractility. None of these are sensitive or specific in isolation. Bedside echo signs of right ventricular strain include a dilated right ventricle, septal flattening or D sign, McConnell's sign, akinesis of the mid-free wall with preserved apical contractility, and a tricuspid annular plane systolic excursion below 17 millimeters. The 60-60 sign is pulmonary acceleration time below 60 milliseconds with tricuspid regurgitant gradient below 60 millimeters of mercury. The diagnostic approach starts with pretest probability. Very low-risk patients may meet PERC criteria and need no further workup. Low-risk patients can use D-dimer. Intermediate-risk patients may need imaging directly. High-risk patients should proceed to imaging without a D-dimer escape. Because a negative D-dimer cannot exclude high-probability PE, the principle is the right test for the right risk group. The PERC rule, or PE rule-out criteria, is applied only to patients with low pretest probability and a Gestalt PE risk below 15%. There are 8 criteria, and all must be negative to rule out PE without further testing. Age under 50, heart rate under 100, oxygen saturation on room air greater than 94%, no prior DVT or PE, no recent trauma or surgery within 4 weeks, no hemoptysis, no exogenous estrogen use, and no unilateral leg swelling. The board trap is applying PERC to a non-low risk patient. PERC does not apply when pretest probability is moderate or high. The Wells score for pulmonary embolism uses 7 criteria. Clinical signs of DVT, 3 points. PE is the most likely diagnosis, 3 points. Heart rate above 100, 1.5 points. Immobilization or surgery within 4 weeks, 1.5 points. Prior DVT or PE, 1.5 points. Hemoptysis, 1 point. And malignancy, 1 point. A score below 2 is low probability. 2 to 6 is moderate. Greater than 6 is high probability. The modified or two-tier Wells calls it PE likely if the score is greater than 4, and PE unlikely if 4 or below. The Years algorithm is the alternative. 3 items: clinical DVT signs, hemoptysis, PE most likely, with an adjusted D-dimer cutoff of 1,000 if 0 items are present. The board concept is using Wells to stratify, then choosing D-dimer versus imaging based on group. D-dimer is most useful in low to intermediate pre-test probability patients. The standard cutoff is 500 nanograms per milliliter or 0.5 micrograms per milliliter of fibrinogen equivalent units. The age-adjusted cutoff for patients over 50 is age times 10 in nanograms per milliliter. So, a 70-year-old has a cutoff of 700. Age-adjusting improves specificity without sacrificing safety in appropriate patients. The classic distractor, a high pretest probability vignette with a negative D-dimer offered as a discharge option. Skip the D-dimer, go straight to CT pulmonary angiography. A negative D-dimer does not exclude high probability PE. The PESI and sPESI scores stratify patients with confirmed PE by mortality risk. PESI is the Pulmonary Embolism Severity Index. The simplified version, sPESI, uses 6 criteria: age over 80, history of cancer, history of chronic cardiopulmonary disease, heart rate above 100, systolic blood pressure below 100, and oxygen saturation below 90%. 0 points is low risk and may be considered for outpatient management with appropriate follow-up. 1 or more points is higher risk. The board concept is that PESI guides disposition. Who can go home? Who needs admission? PE severity is classified as massive, submassive, or low risk. Massive PE is PE with sustained hypotension, defined as systolic blood pressure less than 90 for at least 15 minutes or requiring vasopressors, persistent profound bradycardia, or cardiac arrest. Submassive, also called intermediate risk PE, is normotensive with either right ventricular dysfunction on echo or CT or biomarker elevation, troponin or BNP. Low risk PE is normotensive without right ventricular dysfunction or biomarker elevation. This classification drives the treatment intensity decision. Massive PE management is resuscitation plus reperfusion. Resuscitate with cautious crystalloid, avoid over-resuscitation that worsens right ventricular failure, norepinephrine for hypotension, and oxygen. Anticoagulate with unfractionated heparin. Systemic thrombolysis is indicated unless contraindicated. Alteplase 100 mg intravenous over 2 hours or 50 mg as a push over 1 to 2 minutes for cardiac arrest with suspected PE. If thrombolysis is contraindicated, consider catheter-directed therapy or surgical embolectomy. PERT activation, when available, is high yield. Submassive PE is anticoagulation with close monitoring. Most patients do not receive thrombolysis, but deterioration changes the plan. Catheter-directed thrombolysis or mechanical thrombectomy may be considered for selected patients with severe right ventricular dysfunction, refractory hypoxemia, or worsening clinical status. ICU or step-down admission is appropriate. The board concept is that submassive PE is a watching with intent disease. Anticoagulate, observe, escalate if needed. Low-risk PE may be candidates for outpatient anticoagulation in selected cases. The Hestia criteria identify patients safe for home treatment. Hemodynamically stable, no thrombolysis or embolectomy needed, no active bleeding, less than 24 hours of oxygen needed for saturation above 90%, no PE during anticoagulation, no severe pain needing intravenous analgesia, no medical or social reason for admission, creatinine clearance over 30, no severe liver disease, not pregnant, and no documented history of heparin-induced thrombocytopenia. The board concept is that low-risk PE plus reliable follow-up may be safer at home than admitted. Thrombolytics for PE are most commonly alteplase. Standard regimen is 100 mg intravenous over 2 hours. For cardiac arrest with suspected PE, the dose is 50 mg intravenous push, followed by continued CPR for at least 60 to 90 minutes before terminating efforts. Absolute contraindications include any prior intracranial hemorrhage, structural cerebrovascular lesion, intracranial malignancy, ischemic stroke within 3 months, except acute stroke within 4.5 hours, recent significant head trauma, suspected aortic dissection, and active bleeding. Relative contraindications include age over 75, recent surgery, recent gastrointestinal bleeding, anticoagulation, and severe hypertension. The board trap is giving thrombolytics in stable low-risk PE. Risk of intracranial hemorrhage outweighs benefit. Catheter-directed therapy and the Pulmonary Embolism Response Team are evolving options. Catheter-directed thrombolysis delivers a lower dose of thrombolytic directly into the pulmonary artery, reducing systemic bleeding risk. Mechanical thrombectomy removes clot without thrombolytic. These are used for selected massive and submassive PE patients, particularly when systemic thrombolysis is contraindicated or has failed. PERT, the Pulmonary Embolism Response Team, brings together emergency medicine, cardiology, pulmonology, interventional radiology, and cardiothoracic surgery to make rapid decisions. PERT activation should be considered for any massive or high-risk submassive PE. DVT diagnosis starts with the Wells score for DVT, which differs from the PE Wells score. Compression ultrasound is the first-line imaging test. Proximal DVT is defined as clot in the popliteal vein or above, with the superficial femoral being the most commonly involved, and proximal clot always gets treated. Distal or calf vein DVT is the debate. Surveillance ultrasound at 1 week versus anticoagulation. Symptomatic calf DVT generally gets treated. The board concept is that compression ultrasound is the answer for DVT diagnosis, not D-dimer in isolation. DVT treatment is anticoagulation. Proximal DVT generally needs anticoagulation for at least 3 months. Distal DVT may be managed with serial ultrasound or anticoagulation depending on risk. Phlegmasia is a limb-threatening emergency from massive proximal venous obstruction. Phlegmasia ceruleum dolens is the severe form with cyanosis and arterial compromise. Treatment is urgent anticoagulation plus catheter-directed thrombolysis or thrombectomy with vascular surgery and interventional radiology consultation. The board trap is treating phlegmasia like routine DVT. Anticoagulation choice depends on stability, renal function, bleeding risk, pregnancy, cancer, and whether procedures or thrombolysis may occur. Unfractionated heparin is preferred when reversibility, procedures, or thrombolysis is anticipated. Bolus is 80 units per kilogram. Infusion is 18 units per kilogram per hour, titrated to anti-10A or PTT. Enoxaparin is 1 milligram per kilogram subcutaneously every 12 hours, adjusted for renal function and weight. Direct oral anticoagulants for PE include apixaban, 10 milligrams twice daily for 7 days, then 5 milligrams twice daily, and rivaroxaban, 15 milligrams twice daily for 21 days, then 20 milligrams daily. The board advantage of the DOACs is no parenteral bridge required. The contraindications are pregnancy, severe renal impairment, creatinine clearance below 30 for apixaban, below 15 for rivaroxaban, severe hepatic impairment, and mechanical valves. Warfarin is rarely first line in the ED, but may be relevant for valve patients or specific scenarios. PE in pregnancy requires special considerations. Pregnancy is a hypercoagulable state, and PE is a leading cause of pregnancy-related mortality. Diagnostic algorithms include the Years algorithm adapted for pregnancy. Imaging options include CT pulmonary angiography or VQ scan. Fetal shielding is no longer routinely recommended per the American Association of Physicists in Medicine. The board favorite, with a normal chest X-ray in pregnancy, VQ scan is often preferred to reduce maternal breast radiation exposure. Both modalities deliver fetal doses well below the teratogenic threshold. Treatment is low molecular weight heparin. Warfarin is teratogenic and the direct oral anticoagulants are contraindicated in pregnancy. The board concept is that PE evaluation should not be avoided in pregnancy. Maternal mortality is the greater risk. The board traps are predictable. Applying PERC to a non-low risk patient. Ordering D-dimer in high pretest probability PE. Missing PE and syncope, or new atrial fibrillation with shock. Giving thrombolytics to stable low risk PE. Forgetting that right ventricular failure does not tolerate aggressive fluid resuscitation. Avoiding PE workup in pregnancy. And treating phlegmasia like routine DVT. D-dimer is the wrong test in high pretest probability PE. Case 1. A 62-year-old woman, 3 days after knee replacement, presents with altered mental status, new atrial fibrillation with rapid ventricular response, and hypotension. Acute kidney injury complicates CT angiography. Bedside echo shows a dilated right ventricle, septal flattening, and McConnell's sign. This is high probability massive PE. Anticoagulate immediately with unfractionated heparin. Consider systemic thrombolysis or catheter-directed therapy. Activate PERT. Avoid aggressive fluid resuscitation. Norepinephrine for hypotension. The board trap is anchoring on atrial fibrillation as the primary diagnosis. Case 2. A 48-year-old man presents with dyspnea and pleuritic chest pain. Heart rate is 110. Blood pressure is 110/70. CT confirms bilateral pulmonary emboli. Echo shows right ventricular dilation with preserved blood pressure. Troponin is mildly elevated. This is submassive PE. Anticoagulate with heparin, admit to step down, or ICU, and monitor closely. Consider PERT activation if there is concern for deterioration. The board trap is giving systemic thrombolysis to a stable patient with right ventricular strain. Question 1. A low-risk 35-year-old patient with chest pain and dyspnea is PERC negative. What is the next step? The answer is no further testing for PE is needed. PERC negative low-risk patients have a post-test probability below the testing threshold. The board trap is testing low-risk patients into false positive results. Question 2. A pulmonary embolism patient is hypotensive with bedside echo showing right ventricular strain. What is the next best step? The answer is anticoagulation plus systemic thrombolysis or catheter-directed therapy if no contraindication with PERT activation. The board trap is treating massive PE like stable PE. Question 3. A patient has high pretest probability for pulmonary embolism. The D-dimer returns negative. What is the next step? The answer is imaging is still indicated. D-dimer should not be used to exclude high probability PE. The board trap is using the wrong test in the wrong patient. The final takeaways are these. Recognize the dangerous PE phenotype early, syncope, hypotension, new atrial fibrillation with shock, hypoxia, or arrest. Treat physiology before certainty when the patient is unstable. Use risk stratification, PERC, Wells, PESI, to choose the right test for the right group. D-dimer cannot rule out high pretest probability PE. Bedside echo can support the diagnosis when imaging is delayed. Massive PE gets thrombolysis or catheter-directed therapy. Submassive PE gets anticoagulation with vigilance. Low-risk PE may go home with anticoagulation in selected cases. Pregnancy is not a reason to skip PE workup. And phlegmasia is a limb-threatening emergency, not routine DVT. Thrombolytics are the wrong answer in stable low-risk PE. References for this lecture include Rosen's Emergency Medicine, 10th edition, Foundations of Emergency Medicine Board Review, the American College of Chest Physicians Guidelines for Venous Thromboembolism, the European Society of Cardiology Guidelines for Acute Pulmonary Embolism, the PETHO trial for submassive PE thrombolysis, the Hestia criteria for outpatient PE treatment, and the years algorithm for PE and pregnancy. Local PERT protocols and institutional anticoagulation pathways guide site-specific decisions.